Jane Roberts, and I'm with Dr. Stephen Threlkeld this afternoon. He's an infectious disease expert in Memphis. We've heard a lot from him and a lot about his work. He's also co-director of infection control at Baptist hospitals. So this afternoon, Dr. Threlkeld, I'm wanting to talk to you about the fact that for every hospital bed in Shelby County, we have 339 people. Do we have enough hospital beds in the county if we have a crisis?
Well, it's natural to see a lot of concern about that issue, given what we've seen internationally as it's played out in China and even Italy now. They've had some troubles with things being strapped fairly significantly in the healthcare system. I would say this: we have a lot of ability for critical care. We have a lot of ventilators. We have a lot of ICU beds. We even have a lot of ECMO capability, adult sort of artificial lung function here at this hospital. So I think we're better off in a lot of ways than some of these other countries, but naturally it's a concern, and I think it's been a prime mover in some of these issues in closing schools and meetings and basketball games, because what we want to do, in addition to just save lives outright, we want to make sure that the system is not overloaded, which is what we're talking about. And one of the ways to do that is to, the term that's being thrown around now is to blunt the curve. If a number, say 1,000 people are going to get sick, it's much better for that to happen over 6 months than it is over 1 month. It taxes the system much less. There are more beds available. There's more just manpower. Part of the problem of these things is having enough doctors, nurses, and people to sort of get the job done. So we're hopeful that it's enough, but the simple reality is that this is a new time and a new virus, and so we have to plan for the worst. And so we're doing a lot, I know at our hospital, simply by revamping some rooms to make them negative pressure rooms so that we can do a better job of isolating patients. We've opened up a number of those beds by converting them to negative pressure rooms. We've shifted some things around, and we have a heart transplant program and an ECMO unit and other sort of things that are geographically sort of distributed, and we're prepared to move some of those things around and to make some adjustments. And I think everybody in the community will be. And it may, if things were bad enough, would take some cooperation among institutions and so forth.
Dr. Threlkeld, another concern is that we are surrounded by counties that either have lost their community hospitals or have very small hospitals. So presumably those people would come here to be cared for. That adds a whole nother layer of people trying to get in. What do you think?
Well, it does make it for some increased complexity. I know within the Baptist system there is a tight network of many facilities across North Mississippi, Eastern Arkansas, West Tennessee, and so we have central bed planning and offices that can help distribute those folks with nurses and doctors available to decide where those people can be best served. It may be that the sickest people, like we've talked about, that might need the highest technology would come to Memphis to get their care, but a lot of these patients, remember, will be much less ill than that. In fact, most people will be much less ill than that. And so having the technology or having the ability to coordinate certainly within a system and put people in the appropriate level of complexity for care is going to be very important, because the logistics, as you say, are going to be very important if we get a lot of cases. And we have to plan for there being a lot of cases.
And you mentioned earlier when we were visiting about having a van in the parking lot where you're hoping to do some testing. How's that working, or how will it work?
Just really ramping it up now, and we have a converted mammography van that we have rigged for testing for COVID-19. And so the idea of that is obviously to do several things. It routes people to a place where they can be efficiently looked at. A lot of those people aren't going to be ill. And I would say it's important, and we don't want people, at least at this point, coming in who don't have any symptoms and no exposures. It's probably not enough to be tested in that sort of situation. But for somebody who's had an exposure or has a compatible illness, they can come in without actually going through the emergency department system, which is the possibility of exposing someone unnecessarily. We control that, I think, pretty well and have planned for that, but that's still always possible. So it makes for more efficiency and also allows for more testing.